Good afternoon and welcome to another Webinar Wednesday. Today we are joined by James Freeman, Multi-Vendor Modality Manager, CT, PT, PET, CT Nuclear at Philips Healthcare and All Parts Medical. Webinar Wednesday would like to thank today's sponsor, All Parts Medical. All Parts Medical provides multi-modality, multi-OEM replacement parts from its 158,000 square foot facilities in Nashville, Tennessee. In addition to parts sales, All Parts also provides customers an extensive array of in-depth training classes and technical support before and after the sale. An ISO certified quality management system helps deliver an industry-leading warranty rate. So for more information, please visit allpartsmedical.com. Today's webinar, as usual, is eligible for one CE credit from the ACI, and you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your one CE credit, and you'll be able to download your certificate directly from your computer once you've submitted your survey. If you have any questions, you can reach us at webinar@mdpublishing.com. Now, just a quick reminder about our fall MD Expo. We're heading to the Rosen Shingle Creek Hotel in Orlando, Florida, and that's October the 13th, the 15th. So please join us for 3 days of education, networking, and the latest advances in medical technology products and services. So for more information and registration details, please visit mdexpo.com. Okay, let's kick off today's webinar by giving away one of our brand new Webinar Wednesday trucker hats. So using the questions feature on your screen, let me know the answer to the following trivia question. Today is National Potato Day. Mr. and Mrs. Potato Head are iconic supporting stars in what movie franchise? I'll reveal the answer and our winner at the end of the webinar. We'll be wrapping up today's presentation with a live Q&A, so please submit your questions anytime using the questions feature on your screen. Now, as I mentioned earlier, our presenter today is James Freeman. So, James, you may begin whenever you're ready.
Thank you for that introduction, and good day to everyone. Thank you for spending your time with us. We hope to give you some good information with regards to CT and with regards to, I'll call it the agenda here. So cover a little bit of my background in CT, how I got started, those kind of things for those who are interested maybe in a career. And hopefully you will pick a career in imaging as it helps people's lives in a great way. And I appreciate my time being able to do that as well. With regards to the advances in CT, we'll go over spectral CT. It's been around more than in 2021, but it started really gaining traction with the advent of more technologies moving forward and faster computers. In 2022, and a spread out from that was photon counting CT as a first introduction, not really in the market yet, but really started moving forward in that way. Then clinical review in 23, and then AI expansion and really workflows started moving more and more involved in the products. And then in 2025, we see more evaluation and more integration. And then in 26, basically kind of the AI explosion as it's hitting the market is also engaged in the newer products as well. And then to sum all of it up, a lot of the elements that we're doing with CT, how we service the CT, how much does it really change versus how much it stays the same, and then the advent of what really enables us to service CT, and then what we do here at All Parts. So we'll kind of move forward through that list on the agenda here. So in the 70s, I serviced radar at F4 Phantoms. Okay, so I had electronics training and technical schools with the Air Force in the late 70s. And then in the 80s, I started off with GE in 1982, doing X-ray, and then in 83 CT products. So seeing it from basically the ground experience. My experience with CT professionally has just been ever growing. We started off with computerized tomography. So computers, the growth of computers and the change in the industry of computers has really moved forward and expanded what we could do. And with my personal journey, working in hospitals, also having hospital procedures and clinical evaluations, even on myself, all right, and our family members, and seeing how important what imaging does as an instrument to make people's lives better. On a few occasions in the early 80s, I installed the first CT scanner at a lot of hospitals. Realized CT was new in the late 70s, and it was the first imaging device that could image the brain. And being able to image the brain was a new epiphany in clinical imaging at that point in time. Prior to that, you could see broken bones, a skull fracture, those kind of things, but not really the small intricacies of the brain tissue itself. The first CT scanners in the 70s were head-only CT scanners as the technology gained just experience and being leveraged for imaging. Okay. So with regards to that, electronics, computers, software, all those things I had a personal interest in, and with science, those kind of things. So it really gave me a leg up to see all these things in action and be able to work on them. One of the first CT scanners I worked on was GE 8800, and it came out in really like 1980. And it had a data general computer. And when we worked on CT scanners in those days, we called it being in the right room. The X-ray equipment was probably in one closet, the gantry and the table were in the room, the console in another room, and my slides move faster than I do. But anyway, just an example of what we dealt with in the 80s for computer power, right? We're dealing with a PC that's doing 5 to 10 megahertz. Okay. Now we're dealing with computers that are doing 3 to 5 gigahertz in speed with multiple multi-core processors, not just one processor. So really a massive amount of change in just the past 50 years of what technology is. With regards to having the internet, all those things have brought forth a lot of items with regards to enhancements in our technology. So as an overview of the past 5 years, we talked about conventional CT imaging. We've done webinars in the past on conventional CT. We get CT numbers, alternately with Dr. Hounsfield, who invented CT. They're called Hounsfield units, and the abbreviation is HU. So we have what we call the attenuation coefficients of different materials like water, brain tissue, heart, lungs, liver, and we kind of have defined number ranges of what that is if a system is perfectly calibrated. The next series was dual energy that kind of came out, and that's been out probably about the past 12 years. Dual energy, when it first came out, was looked at as a possibility to enhance iodine and those kind of things in soft tissue. Think of it, instead of using one color of light, you're using two colors of light to better define a material. But we still needed some more enhancements, noise reduction in our data collection, and that kind of elements added to this technology. And then we have AI, and AI, we have multiple disciplines in AI, machine learning, those kind of elements are going to be in play here, not what we get with ChatGPT, which is kind of large language models. Instead, these are defined intelligence embeddedment, basically machine learning. Those kind of elements are more leveraged. And then photon counting and the AI algorithms enhance what we can even see even more so over conventional CT and dual energy. So that's the discussion of what we're going to try to see happen for the next 5 years. So multispectral imaging. Different OEMs have taken different approaches to delivering this technology. Siemens originally started off with a system that had two X-ray tubes, two detectors, and would rotate around you. One would give one energy range, and the other would give the other. So in this case, we're talking about 80,000 volts, 80 kilovolts, and 140,000 volts. 140 penetrates farther through the patient, or attenuates less than 80. And between those two differences, you can enhance soft tissue and bone in different ways. And then if you have iodine introduction, you can even better define it. With regards to Philips, we had two different versions of a detector that would basically how far the X-ray photon penetrates the detector after it's gone through the patient. You can measure that. And then you have binning, where you basically scan one time the patient at 1 kV and then rescan them at another kV. That's one way of doing it as well. And then GE did kV switching for a while. where you basically are collecting twice the amount of data as you rotate around the patient, and every other data set would be of one energy level. So you basically, it's interlaced, you de-interlace it, and one data set's 80 kV, the other one's 140. It could be different kVs in these two scenarios, but either way, what we're trying to do is enhance what we see, and more so in the soft tissue range. So what we do with CT, we just see the composition. We don't just see a grayscale. The grayscale is produced as a result of the CT numbers and how we want to display them. So we could separate the tissues by energy level with spectral CT, and it allows us to better, when we have contrast introduced, to basically, it enhances the contrast where your soft tissue, all these things, and less artifacts. So it strengthens what we can see with regards to vascular, oncology, and all the other elements that we would expect with the use of CT. We enhance those behaviors. So as an example in the video, I mean, not the video, but the picture we see here, conventional, we'll see the image in one way. When we basically, with iodine introduction and spectral CT, we can enhance what we see around that iodine. If you notice where we go up into the kidney area up here, you see more detail than you did prior to the conventional image. And then obviously with CT, we could take that volumetric data set, reconstruct it. In this case, false coloring was added to different elements, and we can actually rotate around the patient as data set from different angles and create a volumetric data set. So it's amazing what we can do nowadays with computers that, 50 years ago was a dream. So conventionally in this chest exam, we could see what a conventional CT would give you. A lot of detail, very useful, but then we can enhance it by either lowering the kV, better detail with soft tissue, and then obviously when iodine is introduced, we can better detail with false coloring in this scenario as well. So then we move into photon counting CT. So when we talked about dual energy KVs, right, we're basically like 80 kV and 140 kV. Now, what if we could define other KVs too? When we produce an X-ray beam out of the X-ray tube, that X-ray beam has a number of different energy levels in it. The peak would be maybe our selected kV, maybe even a few photons over. So for instance, if I selected 120 kV, I could have some X-ray photons that are even more energetic than 120 kV, and then quite a few number are less than that energy. Before, with a conventional detector, I would just see the quantity, I wouldn't see the quality. Now with spectral photon counting CT, I can disseminate which ones of those are different energy levels and how they were absorbed. So this that gives us more sharpness. It gives us improved resolution, and also the materials that the X-ray photons went to, we could better discriminate between them. And so with all this added, we basically get a much better image quality. And then when we say image quality, a reduction in image noise is so much better. So how do we achieve that? Okay, so we have a conventional CT, and as we talked about, we have X-rays going through a scintillator, which is in the detector. That scintillator takes X-rays and converts them to visual light. And then we have the photodiodes that pick up that light. So that's how all conventional X-ray systems work. I mean, CTs used to work with regards to the new detectors. Okay, so with all the energy levels going through, they get accumulated into the scintillator. So it doesn't matter whether they're 80 kV or 140 kV, we get light out. Okay. So with regards to photon counting, now we have a binning process where not only the X-rays come through, but now we can tell which energy levels, how many of these photons came through at, which gives us a better view, our multiple colors, so to speak, of how we had interactions with that attenuation coefficient coming from through the patient. Okay, so you see all the way to the far right, the energy binning example given here, and the number of photons. And then in the image, you have a conventional Hounsfield unit image, where we look at the CT numbers, or Hounsfield units, basically an iodine enhancement when the iodine's introduced, and then contrast versus non-contrast multi-energy images. So at the key elements of all this are that we get a higher resolution, better contrast, lower image noise. The spectral imaging gives us better detail what the material is. And on top of that, because of the newer algorithms that enhance this data set and the noise being lower in the image, we can actually reduce radiation, because the number of photons that we can produce less photons out of the X-ray tube, aka lower current going through the X-ray tube, which then allows this whole function to actually improve our quality of health by not getting as much X-ray. So it enhances all these functions. So current systems in the market, as of this year, some of these units like the GE system was just introduced earlier this year. So they're just now reaching the market. So we have the Siemens Alpha Peak, how it bends, the type of detector material it uses. Then you have GE taking a slightly different approach with their detector technology. Canon using somewhat the way Siemens does it, but the same way. And then you have Philips doing the dual energy spectral imaging as well with our product. So as you can tell, very competitive. There's not a lot of, these are all high-end systems. So as the technology gets more involved and length in time, some of these trickle down into the smaller or older CT scanners as well, not older, but smaller models, so to speak. So these are the top premier systems. And then as technology gets leveled out to the marketplace, this technology will then filter into other products, other CT products as well. So you'll see this new acronym. What is PCCT? It's photon counting CT is the new acronym of the day, so to speak. And as the resolution we talked about, the lower noise, the better data set from the spectral data set, allows us to better tailor what the patient's dose is going to be, and especially like pediatrics, those kind of things. So as clinical has improved, first of all these technologies have to be evaluated, right? So every one of these groups that you see here took a challenge with regards to photon counting CT to see how well it would enhance that section of the studies that CTs are leveraged for. So we have cardiac, definitely helps with calcium scoring, stents, plaque, because we could better discern those kind of elements as well. And then obviously the enhancement of iodine as it flows through our body when we do a cardiac study as well. So better for lungs, oncology, for tumor detection, better differentiation in soft tissue is what this really enhances. So a small smudge or something that we might see in the image would be enhanced to actually be better defined, and actually a better way of determining the CT numbers to see how, if that, what version of tumor that might be, not just that it's a tumor there spatially, but also the characteristics of that tumor as well. And then we talked about pediatrics doing lower dose techniques, enhances that. Plus, bone marrow, all those kind of things. As we get older, some of these things start to become more of an issue with us. And then obviously neuro and stroke and trauma and blood flow studies with the brain as well. So it's really a blessed time that we live in now, when the technology can really help people's lives. So as we talk about AI expanding in CT workflows, don't think of this as one AI element within the constraints of being leveraged on a CT. We're dealing with multiple AI instances here and doing different functions, okay, just processes. So from the hospital clinical side, ordering and scheduling CT, what size is the patient, what kind of study are we going to do, all those elements would be a prescription. Normally a tech would then take that information and then figure out how to leverage that information with a protocol on the CT. Now with 3D cameras that are mounted above the patient table, as they load the patient on the table, the 3D camera can say, oh, we're doing a head study. So it automatically can size that patient's head. Instead of overscanning the patient, aka introducing more dose, now that range is limited. Also, if the patient's longer or shorter, the camera picks that up when you're doing chest and those kind of things to help define the protocol, the ranges that we're going to be actually scanning with. So those are enhancements with regards to using a camera and modifying the front end protocols that have been defined by that OEM on that product to help the tech better create a protocol that's going to be useful for that scan for that patient. Then we talk about the data acquisition side where we scan the patient, and now that data, that dose, through enhanced image reconstruction algorithms and the feedback of that data into reoccurring noise reduction algorithms to produce a better quality image. That's another AI element that's added for image reconstruction. Then we have another AI element in number 5 here, where basically the radiologist is reading what the prescription was for, whether it was for identifying a certain area of anatomy or something that the scan was study was ordered for. But now you have another group of people, basically radiologists and other people that have defined what an AI should be looking for as well in that same image set. So think of it as another set of radiologists looking at that image besides just the radiologist doing the review, and identifying other elements that might be important to that patient's health that weren't part of the order. I personally have experienced that as well. And in fact, I have a CT scan tomorrow based on a scan I had done 3 weeks ago for a different problem. So this is a very comes to home to me very importantly of how all these things work, because I've seen it how it's used, both my wife and I, and the AI enhancement for reviewing older CTs that we've had before as well. And then you get into the reporting element where the report generated is not just specifically for the study that was ordered, but also other areas of interest that would be important to you and your family's life. And then obviously, the statistics of these things feeding back into making the products better and AI better going forward when some of these things were basically verified to be true. So, and then now the hospital can study the populations of all these studies as well and how well it's improved people's lives. So you could tell across the bottom, right? We're reducing dose. We're standardizing where the product, the CT product, is being used in a more consistent way. It's not technologist version variations. We have standardized things that we would see basically like a photo detector would be on an older X-ray room where they had ionizing detectors that you didn't have to have the text dial in the technique. The system actually would produce a very good quality image based on the results of what you were looking for. The efficiency, reduced time of image reconstruction, better image reduction of noise, all those things can make everybody's lives better. So CT has become a mainframe of basically how a hospital can function with regards to diagnostic capabilities that are further enhanced with AI technologies. So a couple examples. I mean, we talked about what it does, but the visuals of improvement. For instance, the photon counting CT over here, the lung, the nodule in the bottom of the lung, lower lobe of the lung, is really enhanced even more so. If you look at the livers, but slightly below it, you see where you didn't really see much differentiation in CT numbers with the conventional CT, whereas with photon counting, the different energy levels really detail the soft tissue much better to enhance. Hey, there's actually a lesion, could be a cancer in that person as well. And then when we get into cardiac CTA, the enhancement of just the elements that we could see and the detail that we could see so much better without the noise, inherent noise in the image. And then obviously metal image improvements with reduction to artifacts from metal. You could better define a hip joint in this case, or artificial joints, knee replacements, those kind of things, where the metal would hide any of the soft tissue around that area that we're actually worried about. Soft tissue is more of what we are concerned with, not necessarily the bone is important, obviously, making sure the supporting structure is there, but the soft tissue that's around that bone and how the muscles are tied in, all the other elements. So again, it enhances clinical usage even more so. So, obviously integration of spectral, AI, photo counting brings all these elements together in a stronger way to impact our lives. It just adds spectral CT adds more information about the tissue. Photon counting improves how X-rays are detected, lowering dose as well, and reducing noise so we could better see that image. And then AI is enhancing. AI is basically extension of what we would do had we had the time to do it, right? So AI is helping with regards to the front end, helping better define the protocols, the scan ranges, uh, the reconstruction of the image data, how it's going to enhance the reconstruction of a given data set, and then even the evaluation through machine learning AI on what to look for in that image that the radiologist is now multiple radiologists are looking at the data set instead of just the one reading the study. So it makes for an assistant in clinical decisions much better and more useful as well. So just to reiterate, we are not just dealing with one AI here. We're dealing with different AI elements to perform a scan and the results of that scan. So we talked about positioning, protocol optimization, dose optimization, even motion management, where if the patient moves just a little bit, we may not use some of that data set. So all that's improved on the acquisition side. Then in the reconstruction, we're using advanced algorithms that are kind of feedback with AI introduction to reduce motion, artifacts, improve low dose images, and then improved resolution as well. And then you get into the AI part where you have the interpretation side, where lesions, segmentation, measurements, quantifications, and priorities of different elements within that image are enhanced into a reporting and workflow structure that now says, hey, not only the study that you just performed for this reason, here's the results for that with the radiologist review, but also here's some other elements that was discovered during the scan that may be important for patient good outcomes. So that leads to follow-up tracking. And I can tell you all elements this past couple of weeks have been involved in just me personally with CT being with my experience with CT just in the past couple of weeks. So it's really happening today, and being how much advantage it is to us to be blessed by these technologies as well. So some of the things that brings to mind with regards to serviceability of a CT scanner. We still have X-ray tubes. They're still not very efficient, okay? But we still need an X-ray source. All X-ray tubes give out a spectral of images, of energies, but now we take advantage of that and it's not wasted anymore. So that's improved. We can have lower dose. Lower dose means we're producing less, we will need less X-ray photons, which means we'll reduce the amount of current we're running through the tube. So that means that we'll extend the life of tubes. But we'll still have X-ray generator parts, high voltage tanks, inverters that are going to drive the power that the X-ray tubes utilize. I mean, we're talking anywhere in CT, 80,000 volts is typically the lower end of that element, and then we go up to 140,000 volts. Uh, that's amazing how much energy we are putting through that X-ray tube to produce X-rays at a efficiency of only about 2%. Okay, but it's still useful, but we generate a lot of heat. So that heat fans, all those things in the gantry, getting that heat out of that gantry is still very important. How we do it, either through water cooling or air cooling. And then obviously we talked about leveraging computers, how much they've changed. The first computer I worked with on an 8800 CT scanner had 96K of RAM, operated at 6 megahertz. Okay, image reconstruction with an array processor took a minute and a half per image. Now we're getting like 20 images per minute in image reconstruction. It's amazing what we have. So the computers obviously leveraged to such a higher degree, now running AI agents on them as well to perform all these tasks. So multiple uses of computers. That's still relevant for running diagnostics. On the system, we leverage the computers to do it also. So all these things are essential. We still are going to use computers. We have GPUs, we're using for image reconstruction. And then we have subsystems that use computers, embedded computers in all the hardware, moving the X-ray table up and down, rotating the gantry, selecting the data collection with the detectors, and the control of that. So what's changing for multispectral down and photon counting is our DAS DMS detector modules are going to be newer, maybe more sensitive to X-ray. I don't know. X-ray is, we have a function in X-ray called beam hardening, where as an X-ray photon travels through a crystal, it degrades the crystal over time. So these newer detectors, we don't know what the risk is going to be in failure, if they're going to fail sooner or not, depending on the utilization. But the fact that we're using lower dose, that would help extend the life of detector modules as well. And then conventionally, we have to rotate around the patient to produce a CT scan data set. So we'll definitely still have axial drive and amplifiers for it. And then we have patient tables where we can have errors with going up and down or in and out. So common issues that we always experience with CT are there as well. So when a service provider, will ask for service regards to uh, who's going to deliver it, how they're going to deliver it to keep that product up and running. Obviously, a lot of things we have to evaluate. What is the cost of that product, and where does the cost break down once we're doing the service in that product? So we have X-ray tubes. That is 70% of the cost of a CT scanner. A lot of times is the X-ray tube itself. Whereas some X-ray tubes are in their neighborhood of $250,000 for an X-ray tube from the OEMs. So you obviously want that tube to last and last a long time, but they are, as I call them, my printer cartridges in CT. They're going to go out. Average lifespan on a CT, conventional CTs anyway, have been 22 to 28 months, somewhere in there on average. It doesn't take into account a hospital that's doing, a lot of patients every year. It's kind of my average model of a generalized population. We've seen some sites where X-ray tubes are going twice a year on a CT scanner because it's doing 50 patients a day. With regards to an ER environment, those kind of things. But overall, in the population and other sites, the X-ray tube may last 3 years. They're not doing as many studies. They do low energy studies, those kind of things. So just as an average population, we kind of talk in those terms. And then to support the X-ray tube, we have to create high voltage. So high voltage parts like high voltage tanks, inverters that drive that, and then the computers that support the process. That's about 20% of our cost to serve. And then we have service, the labor part that we provide that ourselves is service personnel. We have PMs that we have to do, and then emergency service calls. And then obviously training. Training is a big impactor to this as well. How effectively you are troubleshooting as an engineer comes into play. The parts, how many parts are you going to leverage? And then how fast you can do the repair and constructively impact customer downtime in a positive way. training impacts those things as well. So less trained individuals may keep a scanner down an extra day, waiting on extra parts to show up because the diagnosis wasn't correct the first time, or they weren't able to troubleshoot as deep as they wanted to, and then come to find out there's a secondary problem that once you fix the primary problem, secondary problem becomes evident, and which it does happen. So all parts has come into more and more of the offering, where GE X-ray tubes were something we worked with other vendors to produce secondary market X-ray tubes for that to lower the cost to serve. But now all parts has leveraged more Siemens X-ray tubes for the Siemens side of the business, for CT and cath labs as well. And then obviously to support these offerings, we have QA bays and that we leverage for training as well. So we have the support for GE tubes and now Siemens tubes in a stronger way. So some of the QA bays we have here for CT, we have more than just CT here. Obviously, we have ultrasound, X-ray, MRI, cath labs, portables as well. But with regards to focusing on just the CT for this presentation, we have the GE Evo CT, Optima 660, Brightspeed, a couple of VCTs because they have different detectors in them, and then a Brightspeed, Lightspeed 5x16. Those are a number of generations of a product that exist. Then Siemens, we have motion, a sensation definition series, perspective series, and then the newer Go Up series. We have two. The reason why is the older version, or the Up series, is a 16 slice system with a lower energy X-ray tube, and then the Go Top has the high energy tube with a 64 slice configuration. So it allows us to support those products and those two X-ray tubes in a broad spectrum of ways. So if you count, we have quite an investment in CTs here that are leveraged for both the repair process and also the training process. When we talk about the repair process, a lot of vendors out there will repair a high voltage tank or something on a bench, but they never actually put it on a scanner to validate that it doesn't have air bubbles in it or something like that. So with regards to here, we actually take the parts that are repaired and put them back on the scanner and validate that we get a good quality image with regards to that scanner. And so the part has been tested on a rotating frame to validate that we have good image quality before that part's taken off and put on the shelf for sale or exchange. So parts could be searched for on the Philips website. I mean, the Philips All Parts website to look for the parts that you're looking for with regards to a lot of modalities. Skip one. Okay, so with regards to CT training, this CT training is open to all parts customers. Okay, so we have the GE series. We teach 3 different GE systems on that training class, which is 10 days. So we also have the emotion class, perspective CT based on the same topology platform, definition series, and then we talked about the Go systems, be the latest that we just introduced. So you can find more information at the allpartsmedical.com training site. So obviously we support more than just CT at All Parts. We've got X-ray, portable X-ray, C-arms, cath labs, ultrasound, biomed as well, and then MRI. In fact, we have a newer GE MR that's just been completed, installed about a couple of weeks ago. So expanding capabilities to support the market. And with that, I'm open to the Q&A.
Great, thanks so much, James. I've got a couple of questions that come in.
Okay.
The first one actually is, what are you personally most looking forward to in new technologies with CT?
Well, like I said, I've just experienced what we have just talked about. Personally, from a personal point of view, I was scanned just a couple of weeks ago for a thyroid issue, and in the process, they find out that I might have a couple of other issues. So I'm going back for another CT tomorrow, and then an MRI for another element that was discovered that the report gave. So from that perspective, that's really enhanced. Seen enhancement in the AI even more so with regards to how it's leveraged. You're taking variability out with regards to different people would use a product differently. I drive a car differently than you would drive a car. So taking that variability out allows consistent image quality. So if a scan of you is done today and then 2 years from now another scan's done, that consistent image would better help with regards to history and stuff as well. And obviously, computers getting more and more advanced is just going to make the modality much more important. When I first started with CT in the late 80s, there was a big push for MR, and it was believed that MR was going to replace a lot of modalities. Not really, but it enhanced what our capabilities with regards to soft tissue around bone and those kind of things is really, and functional MR as well, how your brain and those kind of things work, have been offshoots for even MR that CT doesn't do. Okay.
Okay. I've had a couple of attendees asking, do you think you could go back to the slide that shows your training?
Sure.
I think
Oop,
that one.
right
Yeah,
there.
perfect.
Okay.
Yeah, just so people can make a note of that. So hopefully that will
Okay.
satisfy those attendees.
So if you're going to attend training, we recommend that you have a couple of years of electronics experience, just that you have good hands-on experience with electronics, test equipment, those kind of things. What's not shown on here is a basic CT course that we have, and then also a basic X-ray course. Either a basic X-ray course or a basic CT course is somewhat a prerequisite to getting the training. Um, because we have engineers from different backgrounds. Sometimes we might have an engineer that has been trained on a G system now coming back for a Siemens system that we've experienced, that they have a background on CT, and we're not going to back the class up for that student that may not have any experience. So we kind of level you up before entry into these classes. So we do have some expectations of the students coming in for different levels of training. So like I said, basic CT is a course offering and basic X-ray. And to enter any of these CT courses, you'd have to have either of those. Okay.
Yeah.
Would get us there. Okay.
Okay. This kind of leads me on to another training question. It's concerning biomedical equipment technicians. He's asking how many years of experience as a general BMET do you recommend before specializing in imaging?
That's actually a two-element question. Okay. First element is your technical expertise. If you're good with test equipment, troubleshooting, those kind of elements, get you a head start, and that's a great. I mean, a couple of years of that working in a hospital environment, that's great as well. The other element is a different element, and this is a personal element. Um, realize we're dealing with imaging equipment here that is being leveraged on a daily basis for patient care. So when do we get to work on this equipment? Well, typically they don't want to give it to you until there's no patients to be scanned that day. So we're talking about more after hours service with regards to PMs, those elements as well. So my personal experience is you work a lot of after hours. So if you're okay with longer hours in the day or after hours work like evening shifts, those kind of things, that might be more your game. But if you are looking just for an 8 to 5 job, this isn't going to be the job for you. Okay, because you're dealing with providing people care for people, and that equipment being available on a daily basis. It's not that PMs aren't done on daily basis and those kind of things, but typically a lot of service events, if they can be, will be pushed to after hours. Okay.
Perfect. Okay, another question that's popped up is, will current CT machines become obsolete with the development of these new AI enhancements, or will they be able to be upgraded fairly easily?
Okay, that element is is conventional CTs have, let's look at, we could take it a number of ways here. First of all, CTs on an average basis have about a 15-year lifespan. You'd be surprised at that. Now, obviously, the older ones are going to have multispectral imaging. They're not going to have a few things, but with regards to, there are secondary market workstations that with a conventional CT, I could still share the data of that workstation and it could do AI image recognition, those elements as well. So that's what's been leveraged somewhat in the market already, where older CTs were leveraged for the data acquisition side, and the image is pushed into like a PACS environment for image reconstruction and AI data review. So that's kind of happened already. Okay. But the thing is as expected, a lot of the older scanners have been rescanned or reskinned in with newer computers, newer recon algorithms. So we're using maybe the older hardware side of a scanner with the newer elements of computers and AI in a newer version of that older product. Okay. So as I said before, X-ray tubes, X-ray generator parts, all those things are somewhat common in a newer product. Okay, it's not like recreate them every instance. Those are leveraged into the newer products as we go forward as well. So I hope that answers the question.
Terrific, thank you. Another question here is, do you have any thoughts on recent or future expected changes to facility requirements for installation, i.e. space, utilities, logistics?
Well, obviously you would expect that with the AI, those kind of elements as well, it's a more integrated environment in a hospital. I was thinking about this with regards to the history of CT, with regards to history of electronics and internet. When I first started with CT, a lot of hospitals didn't have CT. They didn't have PACS. So as CT came along and then the internet came along and PACS was introduced, the expansion of all these. Now, there's not going to be as much changes going forward. Support of a CT scanner, depending on who makes it. Some are water cooled, you need chillers, those kind of things. Others are air cooled. Air cooling obviously is beneficial in the United States, but you're talking about globally the use of CT. There's a lot of hospitals that don't have cooling or air conditioning in the third world that leverage water cooling. So in the United States, it's not as much of an issue as it is in the third world countries as well. But CT is definitely branching in all directions.
Perfect. Well, unfortunately, we're coming to the end of our time. So thank you, James, for yet another great and informative presentation. Now, if you'd like more information about today's presentation, please visit allpartsmedical.com. As promised, the answer to today's trivia question is Toy Story. So congratulations to our winner, Derek Lewis in Tennessee. Now, just a quick reminder, you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after we finish today's webinar. You must complete the survey to receive your 1 CE credit from the ACI, and you'll be able to download the certificate directly from your computer once you've submitted the survey. If you have any questions, you can reach us at webinar@mdpublishing.com. Now, if you've missed any of our past webinars, including any by All Parts Medical, please visit webinarwednesday.live to view our whole archive. We'll be back next week with another webinar, so visit webinarwednesday.live for more details and, of course, complimentary registration. So thank you all once again for your time today, and I hope you enjoy the rest of your day.